Hi everyone, we're going to go ahead and get started now. We're actually at 12 o'clock. Miigwech, merci beaucoup, and thank you for joining us for our Lunchtime Health Sciences webinar today on Resilience in Practice, Strengthening Healthcare Through Trauma-Informed Care. The webinar is being delivered today by Josh Noyce. I am Bethany Thompson, the Health Sciences Programs and Partnerships Coordinator, and before we get started, I'll do a land acknowledgement and formally introduce our speaker. Just to quickly review our agenda, we'll do a 5-minute welcome and introduction. Josh will then present his webinar from 12:05 to 12:50, and then we will have a moderated Q&A period at the end. This is a friendly reminder to please keep your microphone off for the duration of the webinar unless you are asking a question or responding to a question posed by the speaker. This will help limit background noise for everybody. A reminder that this webinar is being recorded and will be posted to the Rehabilitation Sciences and Dietetic Practicum Program websites. All of our previous health science webinars are on the NOSM YouTube channel, and you can find the links to those recordings on our Rehabilitation Sciences and Dietetic Practicum Program web sections as well. You can view these archive webinars at any time and receive a certificate for your professional development records when you complete the evaluation. If you do have any questions throughout the presentation, please feel free to put the question in the chat or raise your hand. We will be moderating both. The Truth and Reconciliation, NOSM University respectfully acknowledges our pan-northern campus on the homelands of First Nations and Métis people. The university buildings we occupy in Greater Sudbury and Thunder Bay are located on the territory of the Anishinaabeg Nation, specifically Atikameksheng and Wanapitei First Nations and Fort William First Nation. Beyond a land acknowledgement, we understand that reconciliation is a practice. We gratefully acknowledge the elders and knowledge keepers who share their gifts and teachings with us so that we may better understand and honor their wisdom and that of all the traditional keepers of this land. NOSM University will continue to practice reconciliation by listening, learning, and fostering a culture of mutual respect and trust. I'd like to welcome and introduce Josh Noyce, our presenter for today. Josh Noyce is a Canadian certified physician assistant with clinical experience in primary care and substance use health. Currently, Josh serves as a clinical lecturer at NOSM University and is pursuing a Master of Medical Studies at the same institution. With an interest in medical education and improving patient outcomes, Josh has developed e-learning modules on substance use health and trauma-informed care, focusing on underserved populations, and his research interests include opioid agonist therapy and patient retention in addiction treatment. Merci beaucoup, Miigwech, and thank you, Josh. Thank you for your time today, and we truly appreciate you sharing your knowledge with us, and we're very much looking forward to your talk and opportunities to ask questions on this topic. Josh, I'm going to hand it over to you to present your slides there now.
Thank you very much. Let me just share my screen. And can everybody see fine? Okay, excellent. So good afternoon. My name is Josh Noyce. I'm a physician assistant working in Sudbury, primarily in substance use health as well as primary care. I'll occasionally help teach clinical skills at NOSM, and I do lecture at U of T. I'm currently enrolled in the Masters of Medical Studies program, where I'm looking at patient outcomes compared to methadone versus methadone and slow-release oral morphine for opioid agonist therapies. And I will be speaking today about resilience in practice, strengthening healthcare through trauma-informed care. I've always wanted to say this. I have a disclosure. I was the sub-lead for substance use health for the team primary care project, which designed e-learning modules for postgraduate PAs. This presentation does use some of the information from that project. So we do have some session objectives. So by the end of the session, participants will be able to identify the core principles of trauma-informed care and to begin to apply them within their professional practice. To recognize the signs and symptoms of secondary traumatic stress, vicarious trauma, compassion fatigue, and burnout in healthcare providers, and consider effective self-care strategies to mitigate the impact of trauma exposure and maintain personal and well-being in their professional roles. This is only a cursory review of each topic could likely benefit from its own separate webinar. And I'm not an expert in trauma-informed care, but I'm sharing my insights from my own learning journey. And so I hope this talk inspires further reflection and discussion on this important topic. So there are many forms of trauma, and people experience trauma in different ways. According to the Center of Mental Health, trauma is the lasting emotional response that often results from living through distressing events. Experiencing a traumatic event can harm a person's sense of safety, sense of self, and ability to regulate emotions and navigate relationships. Long after the traumatic event occurs, people with trauma can often feel shame, helplessness, powerlessness, and intense fear. So trauma does have an effect on our behavior, and we've probably heard of the trauma response. Uh, the trauma overwhelms coping ability and impacts psychological and biological functioning. So, if you do recall the fight, flight, or freeze stress response, this is a survival response triggered by stress hormones. So, the fight, flight response causes elevated heart rate, rapid breathing, and muscle tension. And the freeze response is an overwhelmed system causing impaired attention. And so, prolonged or repeated exposures to stress hormones like cortisol can have negative impacts on bodily functions. And trauma also increases risky behaviors such as substance use and susceptibility to health issues, especially without protective factors like stable relationships. So, I want to talk a little bit about trauma informed care. So, what exactly is this? The trauma informed care, as described by the Substance Abuse and Mental Health Services Administration, or SAMHSA for short, is an approach to providing services that acknowledges the wide reaching impact of trauma on individuals and recognizes the potential path towards healing and recovery. It involves incorporating knowledge about trauma into policies, procedures, and practices across different settings, including healthcare. And the goal of trauma informed care is to create an environment that prioritizes safety, trustworthiness, choice, collaboration, and empowerment for individuals who have experienced trauma. So, this approach emphasizes the understanding and meeting the unique needs of trauma survivors while striving to prevent re traumatization and support their journey towards healing. So, the foundational principles of trauma informed care encompass essential knowledge and understanding necessary for the application within one's role. A trauma informed care transcends specific techniques or interventions as its principles are applicable across a variety of care settings. There are six specific core principles put out by SAMHSA, and I'll talk to each of these. So, the first principle is the principle of safety. So, this is ensuring that physical and emotional safety is there by creating a secure and supportive environment that minimizes the risk of re traumatization. The second core principle is trustworthiness and transparency. So, this involves building trust by establishing clear communication and consistent and reliable expectations and maintaining transparency in all interactions and processes. The third is peer support. So, this involves recognizing the value of peer support and promoting connections with individuals who have lived experience of trauma, fostering hope and empowerment and resilience. The fourth is collaboration and mutuality. So, this is encouraging collaborative relationships between providers and individuals receiving care and emphasizing shared decision making and acknowledging the importance of individual strengths and expertise. The fifth is empowerment, voice, and choice. So, this involves promoting individual empowerment, autonomy, and self determination, allowing individuals to have a voice and make choices in their care. And finally, we have cultural, historical, and gender issues, which is recognizing and addressing the impact of culture, history, and gender on trauma experiences and tailoring care to meet the unique needs and backgrounds of individuals. So, what exactly does it mean to be trauma informed? Well, adopting a trauma informed approach involves recognizing the prevalence of trauma and understanding its impacts on individuals. So, there are four key elements to trauma informed care put out by SAMHSA, and they call them the four R's. So, this is about realizing the extensive effects of trauma and the diverse potential pathways to recovery, recognizing the signs and symptoms of trauma in clients, families, staff, and others involved parties, responding by integrating the understanding of trauma into all aspects of service delivery. This includes policies, procedures, and practices, and ultimately resisting re traumatization by avoiding practices that could cause distress or trigger traumatic responses. Helping healthcare providers, this will help healthcare providers create trauma informed environments, and this promotes healing and resilience and safety for individuals. So, the first point we're going to talk about is recognizing trauma. So, individuals you meet may or may not exhibit obvious symptoms of trauma. However, there is a high probability you will encounter a person with a history of exposure to interpersonal trauma. And there are some common conditions in trauma survivors. This can include things like anxiety, depression, anger, substance abuse, and a myriad of physical health issues. A person may not know their symptoms are associated with traumatic events and will often dismiss past events as trivial. We also have to recognize that people experience trauma differently. So, trauma is different depending on the population you're working with. And I have a myriad of examples here of different patient populations, and I can talk to each how they may experience trauma differently. So, for instance, if we start at the top, Indigenous peoples may experience intergenerational trauma, which may cause avoidance of care due to past traumatic experiences. Immigrants and refugees have trauma from war, persecution, and dangerous migration journeys. They may have stressors like racism. People with developmental disabilities have a higher vulnerability to trauma, but often have challenges in expressing those experiences. Women have increased risk of trauma from sexual assault or domestic violence, and men, due to societal masculinity norms, may limit help seeking, and trauma is often underexpressed. For children and youth, trauma impacts developmental stages, and young children may lack the language to describe trauma. For 2S LGBTQ plus communities, trauma from stigma, discrimination, and violence based on sexual orientation or gender identity. Remote northern populations, isolation often intensifies trauma impacts, and there's often limited access to resources. And unhoused populations have high trauma rates, and the harsh conditions often perpetuate re traumatization cycles. So it's just about understanding the types of trauma depending on the patient population you're working with. So you can also see trauma expressed in clinical settings. People with trauma histories may commonly present with a high burden of somatic symptoms, some of which remain medically unexplained, repeat medical visits and diagnostic tests that are ultimately not therapeutic. There could be an avoidance of medical care or downplaying of physical symptoms that may require intrusive exams. They may appear uncooperative or anxious or jumpy during seemingly benign interactions. They could exhibit strong emotional reactions such as crying, signs of panic, irritability, or becoming tearful during an exam without an obvious cause. And overwhelmed trauma survivors may dysregulate, appear angry, or even shut down emotionally. And that's something else that's important to recognize, and that's called a dissociative episode. So, dissociation is a disruption in the normal psychological functioning. Commonly, this can present with signs and symptoms of memory gaps, so unaccounted time, spacing out, a glazed or frozen look or posture. They may appear withdrawn, suddenly become quiet or distractible, difficulty maintaining eye contact or changed posture. They may have trouble concentrating, feeling disconnected to the present, and there is a link of pseudo seizures to dissociation as well. So recognizing these episodes is definitely important. Again, our ultimate goal here is to avoid re-traumatization. So re-traumatization is an unconscious reminder of past trauma. It results in a re-experience of the initial traumatic event. It can be triggered by a number of things: situations, attitudes, expressions, or by certain environments that replicate the dynamics of the original trauma. So this could be a loss of power, control, or a loss of safety. The lack of knowledge and understanding about the impact of trauma can get in the way of providing the most effective care and intervention. So it is our responsibility as care providers to provide a safe space for our patients. So there is hope. Studies in psychology have shown that resources and abilities linked with better adaptation or higher resilience can be developed and exercised. So I have here the definition of resilience from the American Psychological Association. Feel free to read this. But there are some key elements influencing resilience. This includes a personal perspective, so individual outlooks and interactions with the world do improve resilience. Social resources, so the availability and quality of supportive networks, obviously improve the impact of resilience, and coping strategies. So, positive coping strategies and specific approaches to handling stress and adversity. So, how do we enhance resilience? Well, I have a list here and they seem like pretty obvious things, but I think a lot of us, the important thing is we often have to be reminded to do this, especially with busy work life balance. So it's about maintaining wellness, practicing self-care strategies, eating well, exercising, prioritizing sleep, avoiding drugs and limiting alcohol. Peer support is also key. Emotional support from peers can protect against things like burnout and reduce the likeliness of compassion fatigue and vicarious trauma, and we'll talk a bit about that. Building social support networks can create meaningful connections with people we care about and improve our ability to cope with stress. Encouraging play. So, play is more than just amusement, it helps encourage interaction and cooperation with others and improves problem solving. Encouraging other passions and interests, it provides a sense of accomplishment and developing self connection. So, that could be helping reconnect with ourselves through mindfulness, meditation, playing an instrument, spending time in nature, painting, drawing, woodworking, journaling, whatever works for you. So, now let's talk a little bit about the actual implementation of trauma informed care. So, implementing trauma informed care is not really a straightforward process. It's rather a paradigm shift at all levels of an organization. It's kind of about introducing and sustaining trauma awareness, knowledge, and skills into the organizational culture and their practices and the policies. So, it involves consistently and routinely screening for trauma, using evidence based trauma screening treatments, and coordinating with traditional healers if needed, alternative service providers. And the goal of implementing trauma informed care is to ensure that all aspects of service delivery are designed to accommodate the vulnerabilities of these trauma survivors, thereby making services more accessible and appropriate. So, to help us through this, the BC Provincial Mental Health and Substance Use Planning Council has developed a what they call the continuum of trauma informed care. And this is how they suggest the implementation work. So, when implementing this, it's important to recognize that the goal is to not just replace, but to enhance and refine the existing clinical practices while adopting an appropriate approach to address trauma. So, this graphic here shows the continuum, and we'll talk about each point. So, preparing for trauma informed care. This is typically done at the personal level, the practice level, and the organizational level. And I'll speak a little bit about each of these. So, the preparation for trauma informed care involves an ongoing process that includes developing self awareness and gaining an understanding of trauma and recognizing the effects of vicarious trauma. From a or a personal level, would be more about awareness. So that would be reflecting on your own beliefs about trauma and recovery, maybe recognizing triggers on how personal experiences may influence your interactions, engaging in clinical supervision for ongoing self awareness and support. It's making sure you're managing vicarious trauma, um, understanding cultural competency, learning about the culture and social context of populations that you serve, and remaining curious and respectful. From a practice level, this would involve trauma awareness. So, this is recognizing trauma responses in clients, emotional numbness, hypervigilance, dissociation, and reframe behaviors, looking at our language from a strengths based perspective, using open ended, thoughtful questioning. From an organizational level, this is probably the more challenging because you sort of need everyone to opt in. But this is about policy and training, so engaging staff in discussions about becoming trauma informed, including ongoing training on trauma and its effects for all staff. This includes clinical and non clinical. Creating safe environments to ensure that physical and emotional safety for both staff and clients through inclusive policies and clear communication. Establishing protocols to avoid re-traumatization, like clear informed consent and avoiding confrontational approaches. No blame culture. Cultural and systemic changes would be like developing culturally competent practices that acknowledge historical and intergenerational trauma, and shifting the organizational culture towards like a non-hierarchical supportive framework that more prioritizes emotional intelligence and collaboration. So, something that we talked about on a personal and even a practice level for preparing is learning about supportive questioning. So, We talked about this. Supportive questioning is involving asking open-ended questions in a compassionate and non-judgmental manner. And this encourages individuals to express their thoughts and feelings and experiences. So I've put a few examples here of types of open-ended questions and what their benefit is. So for instance, can you tell me more about how you're feeling right now? This encourages sharing of emotions without judgment. What are the main concerns or worries at the moment? This allows identification of primary concerns. What does a good day look like for you, and how can we work towards more of those? Or envisioning positive outcomes and promoting collaboration. How can I assist you in feeling more comfortable during our time together? This promotes comfort and respects individual preferences. Are there certain things that you find particularly challenging or stressful? This is identifying challenges for focused support. So again, supportive questioning is sort of the first step. We also have to consider the language that we use. So we're wanting to look at people first, avoiding deficit based language. Unfortunately, I work in substance use health and we hear the term drug addict quite often. Instead, we typically opt for terms like a person with a substance use disorder. Um, Things like checking pronouns. For example, the facilitator may share their pronouns, and anyone who feels comfortable can do the same. Avoiding ableist language. He uses a wheelchair instead of he's wheelchair bound to focus on the person. Avoiding heteronormative languages, using terms like partner rather than assuming boyfriend or girlfriend. Acknowledging assumptions of possible racism. I realize I made an assumption based on your background and I apologize. Avoiding generalizations. So statements like all teenagers are rebellious. You need to respect individual differences. And admitting what you don't know. I'm not well versed in Indigenous history, but I am open to learning. So the goal again is using people first, strengths based languages, and it's going to help reduce stigma. And this aligns more with the trauma informed care principles. Now we want to talk a bit about engagement. So, people that have experienced trauma are often members of communities who have faced systemic forms of discrimination or live in social circumstances that are full of inequity and may impact their ability to even access these services or engage. So, the BC Trauma Informed Practice Guide does provide 7 strategies to engage patients using trauma informed care, and we'll talk a bit about each. So, the first strategy they suggest is considering all barriers to engagement. So this is using the social determinants of health approach to assist in expanding your comprehension of the life realities of many individuals and the various factors that influence a person or a family's ability to access services like poverty, homelessness, gender, and so forth. Barriers may emerge from existing policies and regulations, such as immigration laws, which may deny health coverage for those without legal status or fear of losing their children, housing or employment if mental health and substance use concerns or trauma are revealed. They could be unseen barriers that are directly or indirectly tied to preventing encounters with institutions and authority. They could include individuals from cultures that have suffered intergenerational opposition or refugees who distrust government organizations. It's about attending to immediate needs. So, addressing essential needs like food, housing, medical care, and safety. And if this falls outside of your organization's mandate, then referring to agencies that can assist is sort of the next step. Um, Being transparent, predictable, and consistent. So, this is offering translation support services if that's required. Keeping promises and clarify actions. So if you agree to make a phone call for this person or send a referral, then do this in a timely manner, and establish healthy boundaries for and define your practice roles. So explain what it is and what it is not going to happen within your capacity. Focus on client information pertinent to the agreed upon scope of work, and ask about trauma specifics only if required for trauma targeted interventions. Maintain a professional tone and also show a sincere care and concern. Start and end sessions punctually. So steps like this, providing clear program and treatment expectations, the entitlements of the individuals utilizing the services, the requirements for attendance and involvement, the regulations concerning substance use or other medications if that plays into it, specific program rules that there may be. You need to maintain clarity and consistency in explaining this. Obtain informed consent using simple language clarifying confidentiality and addressing both verbal and nonverbal communication, and developing grounding strategies collaboratively. So, asking open ended questions to help the patient identify calming strategies and support preferences. So, once we've tackled patient engagement, now we need to talk about how to ask about trauma. Now, once we're comfortable with this, it should be understood that all patients should receive trauma-informed care, regardless if they disclose the trauma history. But when discussing trauma as necessary, there are differing viewpoints that exist in the literature regarding the approach. So what I've done is I've made a little poster with some helpful tips. So this could be, again, disclosures not required, and review and make clear the limits of confidentiality. Avoid power dynamics, so limit questions asked consecutively. Instead, use open-ended responses. And normalize the process, provide rationale for questions, and whether possible, where possible, emphasize that the process is normal. Focus the conversation, keep it on the present. Ask about strengths and goals and interests and coping strategies, community connections, survival strategies, and spirituality. Be selective with the information. Ensure that the information being gathered will strengthen the engagement and recovery. And watch for signs of trauma and respond to it if you do notice it. And offer choice. So emphasize the patient's autonomy by allowing them to select what questions they're comfortable responding to and go at their pace. Once we're comfortable with that, this is about making connections with the trauma response. So during an interaction with trauma survivors, it is possible for a trauma response to be triggered at any moment. While some patients may possess awareness of their triggers, others may still be in the process of understanding and identifying them. So demonstrating compassion and understanding is really important in navigating these circumstances, and this will help them sort of bridge that and make these connections between their past experience and their current circumstances. So by understanding these reactions and linking them, individuals can normalize their experience and gain broader context and empowerment. So here I have a list of possible signs of trauma response that may be seen. So this includes sweating, muscle stiffness, difficulty relaxing, change in breathing, rapid heart rate, a flood of strong emotions, startle response, shakiness, staring into the distance, becoming disconnected, losing focus, inability to concentrate or mind to respond to instructions, and inability to speak. Now we talked a bit about empowerment, and so practitioners can offer practical tools to help them ground and be safe in the present time and in their own bodies. And so as your capability grows, you have a better opportunity to successfully address trauma. So like during a patient encounter, if you recognize a trauma response, there are some steps that you can take to appropriately respond to the situation. Uh, for one, paying attention to the person's body responses and words. So encourage the patient to keep their eyes open during the encounter, provide validation by not interrupting the normal manifestations of their trauma, such as shakiness, tears, trembling, numbness. Offer encouragement and grounding. So while a patient is acutely distressed, encourage and support them with your undivided attention and reassurance of their response. So let them know it's okay to cry, it's okay to feel angry and express these responses. Remain present. Avoid the temptation to talk the patient out of their trauma response, if only to avoid one's uncomfortable feelings about it. Continue to offer grounding and calming. So, calming and grounding should be offered until the patient is present and feels safe and sort of reconnects with their environment. Strength and empowerment and collaboration. So, depending on the severity of the response, ask the patient to check back in with their own body and ask them to reflect on what they need to feel safe. And if they cannot continue, then you need to book a follow up appointment or revisit if needed. And don't go at it alone. So, always, if required, look for peer support to assist with processing and debriefing about these encounters afterwards. And this will help identify gaps in areas that may require further work. So, now that we've talked a little bit about the implementation of trauma informed care, I want to talk a bit about some of the impacts that trauma has. So there's something called secondary trauma conditions. There are four key conditions that may affect healthcare providers working with people who have experienced severe trauma, and we'll talk about each of these. So the first being vicarious trauma. This refers to the negative impact of prolonged exposure to secondary trauma via patient encounters on a healthcare provider or caregiver. So vicarious trauma develops over time in individuals who are constantly exposed to severe adverse events such as violence, abuse, neglect, loss, and suffering. Vicarious trauma can result in a significant shift in a health provider's worldview, disrupting their perceptions of personal safety, control, trust, and self esteem. And it can have profound impacts on a work home life. And some of the symptoms that you'll see is irritability, social withdrawal, overprotective, excessive worrying, overreacting, helplessness, a sense of lack of safety. And we compare that to a secondary traumatic stress. So this is the emotional distress of experience that's experienced by a professional when they're exposed to the traumatic experiences of others. It presents with symptoms similar to like post-traumatic stress disorder. It can develop as a result of a single exposure to a secondary trauma or multiple exposures. It may particularly impact those who have experienced direct trauma themselves. Symptoms can include exhaustion, physical, emotional, and often like physical and emotional exhaustion, sleep difficulties, hypervigilance, perpetual alertness. You know, the inability to turn it off, not feeling safe, jumpiness, avoidance of potential triggers. So they may show signs of delaying on charting on traumas or unable to enjoy forms of entertainment that remind them of patients or personal traumas and recalling or re-experiencing past traumas. The terms secondary traumatic stress and vicarious trauma are often incorrectly used interchangeably, but they are distinct conditions. So secondary traumatic stress can develop over a shorter period of time, whereas vicarious trauma is usually a cumulative effect of repeated exposure to traumatized patients. And then we have compassion fatigue, which is a condition characterized by profound emotional and physical exhaustion caused by exposure to the trauma of others, which can result in decreased empathy for others and feeling helpless or overwhelmed in the face of patient suffering. Uh, Though the risk of developing compassion fatigue increases with prolonged exposure to patient distress and trauma, it can occur suddenly. Compassion fatigue is by no means a benign condition. It can result in serious physical and mental health outcomes for the care providers, and it can also increase the risk of poor clinical judgment, treatment errors for the patients, and it's therefore very important for people working in high risk areas like mental health. They're aware of the warning signs and symptoms and know when to seek help. And I have a list here of signs and symptoms of compassion fatigue, and these are very similar symptoms that we've talked about already. And then finally, we have burnout. Dr. Drawson did a fantastic presentation earlier this year on managing burnout for healthcare professionals. And so this is a brief reminder. Burnout refers to a state of emotional, physical, and mental exhaustion caused by prolonged and excessive work related stress. It occurs when caregivers feel overwhelmed, emotionally drained, and unable to meet the constant demands of their work. It usually develops slowly, and unlike vicarious trauma, secondary traumatic stress, and compassion fatigue, it's not necessarily directly related to exposure to traumatic material. Burnout can be characterized by overwhelming emotional exhaustion, depersonalization and cynicism, and reduced sense of accomplishment and feelings of inefficiency at work. And burnout differs from depression generally in that the symptoms are usually specific to work. They can carry over. But while burnout may impact home life, some people are still able to enjoy their time away from work and be fully engaged in work related activities. Uh, so if you refer to Dr. Drawson's webinar on this, she actually provides a 5-point scale to rate level of burnout, and I would suggest reviewing her webinar again for this valuable content. So, according to the Canadian Medical Association, there are poor provider wellness outcomes were consistently associated with the following demographic groups. So, age of providers under 35 reported the lowest wellness and work satisfaction. Those identifying as women scored lower on health and wellness measures. Practitioners with 6 to 10 years of experience are at a higher risk for stress, burnout, and poor wellness. Caregivers for children, parents, and family members reported poor health and wellness outcomes, and providers in rural and remote areas face greater challenges to wellness. So there is definitely a cost to caring. So let's talk about that. So, if we look at the cost of caring and the consequences of vicarious traumas and secondary traumatic stress, compassion fatigue, and burnout, it does have an impact on the patient, the healthcare provider, and the healthcare system. So, some impacts to the provider are increased somatic symptoms and health issues. They may have heightened anxiety, depression, and risk of suicidal ideation, reduced self care practices and risky behaviors, so increased substance use risk and potential risk for motor vehicle collisions, strain in personal relationships, and higher absenteeism and risk of leaving the field. Now, if we look at the impact on the healthcare system, typically we see reduced provider productivity, increased staff turnover, decreased access to care due to provider shortages, and higher costs due to turnover and reduced efficiency. And from an impact to the patient, you see lower quality and consistency of care, increased risk of treatment and procedural errors, and poor overall patient health outcomes, and satisfaction is reduced with patient care. So is a way to fix this. So, like our patients, each health care provider responds to secondary trauma. Their response is influenced by a number of things. This can be like genetics, personal history, support networks, environment. But there are some evidence based daily strategies that you can employ that have been shown to prevent and also help treat these conditions like vicarious trauma, secondary traumatic stress, compassion fatigue, and burnout. They say it's as simple as ABC. So if we look at the A, this would be awareness, recognizing the warning signs and symptoms of stress and distress, regularly assessing your own well being, and practicing mindfulness and grounding techniques. So B would be balancing caseloads between challenging trauma and routine medical assessments, taking time to eat, exercise, and rest, spending time with friends and family outside work, and using your lunch breaks and vacation time. And there is such a thing as a provider prescription, which is you prescribe yourself 8 hours of work to 8 hours of play to 8 hours of rest. And finally, seeking connections with other people, your faith or spiritual self and nature, participating in continuing medical education, and be cautious with the use of social media and technology as your primary source of connection, as screen time can be overstimulating and it's less personal. There is also a assessing work-life balance questionnaire. It's called the Professional Quality of Life Scale. The purpose of this scale is to measure compassion, satisfaction, compassion fatigue, and burnout. Typically, it's done on 3 to 4 month intervals, but you can do it more often depending on work environments. And it just helps gauge professional satisfaction and wellness over time. And it gives you some insights into your emotional health and it identifies areas for improvement. So, this is free to access online. So, if anyone's interested in doing a self assessment, I would suggest taking a look. The personal preparation plan is adapted from the BC Provincial Mental Health and Substance Use Planning Council, and it gives some helpful questions for self reflection when working with people who experience trauma to ensure your own well being. So, this can include in preparation for an encounter with a patient who has severe trauma history, I will ground myself by doing a full body scan and checking in with myself emotionally, making sure I have refueled my body and having something to eat, drink, and use the restroom. I will remind myself that I am safe. Their trauma is not my trauma. I am doing my best to help this patient. This is not hopeless. I will know the work is starting to affect me negatively when my heart is racing during the patient encounter. I am struggling to sleep well at night. If that starts to happen, I will pause, take a deep breath, do a mindfulness exercise after the encounter. Someone who can offer me support. Typically, I suggest making somebody available for work and at home. And two self care strategies that might help me cope. I put down exercise and meeting up with friends, but again, these are all customizable and it's something that can help with self reflection. We appreciate fostering self care, which includes refueling, prioritizing sleep and rest, eating well, taking our breaks and vacation time, speaking kindly to yourself, and treating yourself as well as you treat your patients. Learning to say no is probably a big one for a lot of people, but it's very important to make sure you're maintaining balance, exercising, unplugging from social media, your phone and screens, and smiling. It really does help. So we talked about mindfulness, but mindfulness is the practice of focusing our attention purposefully on the present moment and accepting it without judgment. So, mindfulness training in healthcare helps clinicians pay attention to what is happening immediately in front of them, opening them to the information being presented in a given moment. So, this helps providers focus on feeling less overburdened, experience greater empathy, develop a deeper connection with patients, and ultimately take more pride and satisfaction in their work. This can be simple as exercises like guided breathing techniques or more focused exercises like body scanning or walking meditation. Uh, it's ways to encourage this into everyday practice would be to just start by paying attention, focus on sights and smells and textures around you, and acknowledge each sense before you move on. Live in the moment, concentrate what is happening to you right now, practice gratitude, focus on breathing, and there are a number of online resources that are very useful for accessing techniques for mindfulness meditation. I've given one example at the bottom here, Care for Caregivers. It's an interesting website that has some access to mindfulness, and it's Canadian. And we also talked about grounding techniques. So while mindfulness encourages us to observe our thoughts and emotions with openness and non judgment, grounding techniques focus specifically on connecting us physically to the present moment. So grounding is particularly helpful when intense emotions or trauma responses arise. Often immediate, it gives you some particularly immediate reassurance and stability. And I've listed a few of the techniques here. Unfortunately, with time, we don't really have a chance to go through a complete exercise. But some of the examples would be something like the solid chair or feet on the floor. And if you're interested, I would suggest going on YouTube and just typing in a grounding technique, solid chair. And there's a number of videos that will have somebody literally walk you through this exercise. And there's some further reading for what I obtained these resources. It was from the BC Provincial Mental Health and Substance Use Planning Council, Appendix 6, but there are a number of online resources. So I've touched on a few spots on where to start. The NHS Auto Guides has a great set of exercises and guiding tools for mental well-being. Um, HealthLink BC has a well-being resources page that has a number of online resources for mindfulness, connection, and healthy mind. Said before, caregiver or Care for Caregivers provides mental health support for professional continuing care providers. And Anxiety Canada does provide access to the Mindshift CBT app if anyone has interested in that. And ultimately, our goal here is compassion satisfaction and vicarious resilience. So, compassion satisfaction refers to the benefits of caring for others and can offset the risks of compassion fatigue. While supporting patients that have experienced trauma, we also bear witness to incredible resilience, the transformative power of recovery, and the human compassion in overcoming personal struggles, which can inspire vicarious resilience in healthcare providers. Some of the emotional benefits of working with patients with interpersonal trauma history can include increased passion and compassion, so greater empathy and dedication in patient care, professional purpose and fulfillment, so enhancing self sense of meaning in your role, better cultural understanding and a broadened awareness of diverse cultures and customs, patient gratitude, so appreciation and acknowledgement from patients, and a personal appreciation, so a renewed gratitude for your own life and experiences. So ultimately, we're inspiring vicarious resilience. And here I also have a few of the resources that I did use specifically to make this talk. Two of them are accessible online. The middle one, Trauma Informed Healthcare Approaches, it is a text that you'd likely have to find through a library resource. And then here are my references. And I can send a more detailed list if needed. Thank you very much. Any questions or discussion?
Hi, Josh. Sheila Renton here. I'm not sure if I should wait to be called or just start talking.
I just start talking.
Okay. Well, first of all, a big thank you. This was a very well done presentation, and I really do appreciate your focus on the healthcare professional aspect. And I was thinking initially it may be hard to deliver trauma-informed care when we ourselves are dealing with our own trauma. And so thank you for spending a good part of the presentation on that topic. I wonder if you can comment, Josh, about how easy it is to start to implement these practices. A couple of times during the presentation you said, and once we are comfortable with this, we can add more levels. And I was thinking, yeah, this may not be something that I would feel comfortable with right off the bat, and obviously practice is important. But can you give any sense of a journey along that line?
Sure. Most of this, as I said in my introduction, I'm no expert in this. This is mostly from my own experiences and my own journey, and trying to implement this in my practice and my understanding. And so I can reflect to the fact that it seems easy, but it is definitely not easy. And from a personal perspective, um, taking the time to recognize forms of trauma and sort of appreciate that, and then making myself aware in clinical settings can be easy, but making the simple changes like making sure that I'm not using incorrect language or making wrong incorrect assumptions, that's a sort of a paradigm shift in my brain. And so that takes time, especially with regards to being comfortable with experiencing somebody going through a traumatic episode or a dissociative episode. Being comfortable in that situation is very difficult, and a lot of people kind of just want to get the heck out of Dodge. But it's really about sort of challenging yourself and so a lot of self reflection. I think it's a lot easier to implement this from a personal and a practice perspective than an organizational perspective. Trying to implement this in an organizational perspective is very daunting in the fact that you kind of have to have everybody on board from front staff to executive level, and it's about going through and finding the sort of the traumatic issues in the organization. And this could be old hierarchical systems and whatnot, and people not feeling like there's like a power dynamic involved that could be something that have to be addressed. But for instance, I'll give you an example that really reflected to me. Looking at two options for our patients that I work in substance use health, where would the trauma from a patient coming into the clinic happen? And typically, the waiting room is probably one of the more traumatic places in a substance use health clinic. You have a diversity of patients, from people that are starting their journey on recovery to people that are well on their way, and you have them interacting, and sometimes it's not a healthy, or sometimes it can be more of a triggering environment. Just in general, patients waiting for long periods of time for appointments increases the risk of anxiety, and it's kind of traumatizing. So from a practice perspective, it was about trying to like figure out ways to make sure that we're not having patients wait too long, and that maybe figure out ways that we can have like certain times of the day where we have like more stabilized patients presenting versus less stabilized patients, so that there's not that risk interaction. It's honestly, it's an ongoing process though. It's just about sort of identifying something and making a change, but like it's definitely not overnight. I don't know if that answers your question, but I hope it does.
Well, yes, thank you. That's very helpful. And obviously, I really appreciate your experience, because it sounds like you're speaking from your own experience, and I really do appreciate that. I'm also imagining being part of a team, whereas you said you can debrief and have shared perspectives. So your example, just even of the waiting room scenario, is very helpful. Thank you very much, Josh. There are several comments in the chat as well. There may be other questions.
8 hours work, 8 hours play, 8 hours rest. That's a tough formula. It is a tough formula, but that was the recommendation. I align with the vicarious resilience slide. This is never been presented in any trauma aware and healthcare focused training, and now very important to highlight how providers can grow. I do agree. It isn't realistic, but it's just implementing the fact that you do need to have rest times, and maybe it's not every day that you have 8 hours of rest, but you do need to have periods during the week where you have time for yourself. Elderly care house play is not quite the word. Well, play is probably the word. It's just we all have different interpretations of what the word play is. But yeah, I appreciate that. But one of the things that I did reflect on too was when you're looking at from an organizational level too, if you're looking at it from a clinical and non-clinical staff perspective, a lot of times you can see higher rates of turnover in front staff, secretaries and stuff, because they're first line seeing patients. They're encountering all of the trauma that's coming in, patients calling in saying, I have to book an appointment. This person's sick or dying, or they're, may have, unfortunately gotten yelled at because the patient wasn't happy with the wait times or the fact that this form wasn't completed. And it seems to be the front staff that deals with a lot of that. And a lot of times there's no areas or time frame for them to sort of debrief, and there's no safe space. They're sort of expected to be there at their desk for 4 hours before lunch, and then take their lunch break and then be back answering phones. And it's just about jumping in between all of this stuff, and it's very overwhelming. So you do see a lot of this in places with high turnover rates. And so creating these safe spaces even for staff can really benefit. What is this? Although I find perspective on dishes, housework, etc. as play. Fair. If you like doing that. Mindfulness for shopping and meal preparation. Cooking. I really like cooking. I find chopping vegetables is like therapeutic for me. So I just have my mise en place and I just chop vegetables for like 40 minutes and I'm happy. Am I missing any other questions?
Sheila Renton again here, Josh. And you mentioned in your declaration that you have been involved in some of the team primary care initiatives. I believe if I understood that correctly. Could you say more about what you did?
Yes, so this was last year. I was involved as a sub lead for the substance use health rule. I guess it was our project head. It was an overarching thing where the leads of the project had found various areas of care that needed like for vulnerable populations. So specifically, we had sub leads that had Indigenous health. I did substance use health. There was somebody that did mental health. There was refugee health, and we were trying to do one with francophone, but we couldn't find a reasonable person to do this. What I did was I made e-learning modules for different things like cannabis use disorder, opiate use disorder, amphetamine use disorder, like stuff like that, and it complemented work placements for physician assistants that were taking this training, and so they were able to work in a substance use health clinic while taking these training e-learning modules as a sort of a supplement to try and boost their clinical practice skills. So that was my role in that.
Thank you. And do you know if those modules are available on the Team Primary Care website?
They are currently being held, I don't know if hostage is the term, by McMaster University. I don't actually know how to access them. So I'm as a primary author, my name's all over it, but I wouldn't even know how to get access to it right now because it was sort of a project that was done. And the hopes was that it would continue on. And I think it's in that that sort of place right now where they're trying to figure out what to do with it and who's going to be hosting this. But opening those modules up would be fantastic, especially the Indigenous health one. I got to review that one, and it was phenomenal. It was several PAs that work in northern Manitoba, some of the fly-in reserves, and they were able to find some people that were professionals or experienced in certain areas, experts, and they were able to make some fantastic slides and show some very in-depth stories and patient experiences. So if they could ever make those available, it'd be great for everybody.
Thank you.
I can email and ask, but I can't promise anything. Well, I can make my slide presentation available as well. I can send it to the updated one to anyone if needed.
Josh, as well, if you'd like to send me the slide deck, I can send it out to all the participants on the call today.
Okay, that's fine. I'll send it after the meeting.
That's great. Does anyone have any other questions today? You can raise your hand or put them in the chat. Slides would be great, thank you. So yeah, if you could send those over, Josh, that'd be great, and I can send them out.
Oh, this is actually part of a much longer talk too. I pared it down, so there are a lot of it had more stats and some other stuff involved too. You got a little more detailed, but I could probably share that presentation as well if needed. I'm just not sure if it's as relevant.
All right. If there are no other questions, I think, oh, sorry. Josh, can you make sure your contact information is on those slides as well?
Yes.
That'd be great. Thank you so much. Great. All right. If there's no other questions there today, I think we'll wrap it up. Thank you so much for presenting today, Josh. We got a lot of great feedback in the chat, and a really great topic, and you had a really wonderful way of summarizing a tough topic. So thank you so much for that. And as I mentioned at the beginning of this webinar, this is recorded and will be posted on our website. So feel free to share with your colleagues if they weren't able to join today.
Appreciate it. Thank you.
Thanks so much, Josh.